Okay.
Okay, great.
Well, welcome back, everyone. We'll get our next session going. And I am delighted to introduce Dr. Manny Moodley for our next speaker and our next presentation. Dr. Moodley is a pediatric neurologist and professor in the Pediatric Neurosciences Department at Dell Children's Hospital in Austin, Texas. He is currently the director of the Pediatric MS and Neuroimmunology Program and co-director of the Dell Children's Neurofibromatosis Center of Excellence. He relocated to Dell Children's Hospital from the Cleveland Clinic 2 years ago. And while at the Cleveland Clinic, he was the director of the Pediatric MS and Neuroimmunology Program and also co-director of the Cleveland Clinic Neurofibromatosis Program for the last 15 years. So Dr. Moodley is going to present on non-tumor issues of the brain and NF1 today. And Dr. Moodley, thank you so much for joining us this afternoon.
Okay, thank you so much, Carrie, for the warm introduction. And it was good to see all the few colleagues that I spoke with a few minutes ago. The talk this afternoon will be a combined talk. I will talk first, and Dr. Ginger Harrod will speak after me. And we both are co-directors of the new Dell Children's NF Center of Excellence. We both don't have any conflicts of interest. And just to give you an overview of what our talks are going to be about, I will talk briefly on the overview of NF1, talk a little about the NIH diagnostic criteria, the 1987 NIH criteria, and then comment a little on the new revised diagnostic criteria. And then I would talk on the neurologic findings, a little on cognitive disorders, learning problems, behavior problems, and also the interesting association with UBOs. Lastly, I will talk on the vascular complication, but this would be very brief, and I would talk a little about Moyamoya Disease. And then following me, Dr. Harrod, who has elected to talk about the tumors. She is our neuro-oncologist, so rightly so. She'll talk about the tumors in NF1, give you an overview, and then the management strategies, outcomes, and prognosis. So that's briefly our plan for today's talk. Okay, so overview of NF1. You've had a number of excellent talks this morning, so my talk might also have some of the information that other speakers gave this morning. But briefly, neurofibromatosis is a term we reserve for 4 distinct genetic neurocutaneous disorders, and these are NF1, NF2, segmental or mosaic NF, and schwannomatosis. For purposes of today's discussion, I'm going to concentrate on NF1. Just an overview again. Remember, NF1 is one of the commonest autosomal dominant condition in pediatric patients. But important to note is that there is a great variability in the clinical expression, and many features show age-dependent penetrance. And I will show you a cartoon later about the discrimination in terms of age and the appearance of the different types of clinical features. There is a spontaneous mutation rate of 50%, and the birth incidence is anywhere between 1 in 3,000 to 1 in 4,000. Currently, there are more than 100,000 people in the USA with NF1, And just to put this into perspective, NF1 is commoner than Duchenne muscular dystrophy, a very common chronic condition in pediatrics, and cystic fibrosis. So that's the perspective you've got to keep in mind. And lastly, it is a multi-system disorder, predominantly affecting the peripheral nervous system and central nervous system, but it can affect the skin, bone, endocrine, GI, and the vascular system. Just to go on the clinical features of NF1, I've just tabulated them in the form of the most common and the least common. As you would see here, the most common clinical features of NF1 includes neurofibromas, Lisch nodules, and café au lait spots in more than 90 to 95% of patients. And of less common presentation would be learning disabilities, skin fold freckling in 60 and 85% of patients, and the rest of the clinical features are below 50%. And don't forget, vascular disease, hemihypertrophy, seizures, scoliosis, optic gliomas are relatively common, but much less than the ones I've just mentioned earlier. Here's a cartoon showing some of the characteristic clinical features that one sees in these patients. If you look at this first picture, that's a picture of the iris, and you can see these coppery brown lesions on the iris, and these are called Lisch nodules. Lisch nodules begin early in childhood, but you don't really see them then. They present characteristically later, young adulthood or in the adult, where Lisch nodules can be present in about 90 to 95% of patients. But in young children, in 1 or 2 year olds, you may not even see it. It would probably be less than 5%. On the right of the Lisch nodule is the café au lait spots, brown macular lesions that are present all over the body, and a very important diagnostic criteria for neurofibromatosis. This picture shows neurofibromas. These are lumps on the skin. They can also be present under the skin. So palpating the patient's body and limbs is an important way of detecting neurofibromas that are subcutaneous. Here's a picture of a child with plexiform neurofibroma, and you can see the disfigurement of the face that this lesion can cause. And on this frame, here's an optic nerve glioma found in about 15 to 20% of patients of NF1. Here's a patient with a bony problem, scoliosis, and these pictures depict pseudarthrosis of the tibia, another very characteristic bony lesion that you would see in NF1 patients. Here's the timeline slide that I was talking to you earlier. So, development of clinical features of NF1. They're not all present at the same time. So therefore, I've divided this into birth, infancy, early childhood, adolescence, and adulthood. So if you look at a child who has NF1 at birth, you may see several café au lait macules. You may see bony problems. You may see plexiform neurofibromas as compared to ordinary neurofibromas, which don't usually present early. So that's all seen between birth and infancy. Occasionally, you might see optic nerve gliomas present just after birth or just before infancy, but it's commoner to be seen in the second phase. That's from infancy to early childhood. So you have patients presenting with learning deficits, ADHD or autism spectrum disorder, motor and or speech delays, and behavior problems. So this is a very difficult period in the management of children with NF because most of the learning problems and the behavior problems seem to be concentrated in this area, infancy to early childhood. And you can also see optic pathway glioma. Okay? The next phase is early childhood to adolescence. During this period, you're going to see skin fold freckling, that's in the armpits and inguinal areas. You're going to see Lisch nodules just appearing, but not in big percentages. You're going to see scoliosis and dermal neurofibromas and paraspinal neurofibromas. So it's important to know this timeline because you won't be looking for lesions that appear later, early on. And also, it's important to know certain lesions are timeline based. For example, caffeole spots, they start at birth, they're born. At birth, you can see them, or early on, you can see them, and they continue to grow in frequency and numbers until about 7 to 8 years of age. And thereafter, the frequency and severity diminishes and they almost disappear. Whereas optic glioma, again, may be found shortly after birth or infancy, and thereafter the incidence goes up 6 to 8 years of life, and then by 10, 11 years, it goes down again. And that's why surveilling these patients is important during that period of time. And lastly, from adolescence to adulthood, you're going to see complications. Malignant peripheral nerve sheath tumors. These are plexiform neurofibromas. About 10 to 15% of them may develop this lesion. You may develop breast cancer, and you might also develop high-grade gliomas. And the gliomas can be mainly in the brain. Okay, so I wanted to go through this timeline because I think it's important to understand that all these lesions come at different times. Okay, let's look at the NIH 1987 diagnostic clinical criteria. The criteria is 7, and you need 2 of the 7 criteria to make a definite clinical diagnosis of NF1. And that is what we commonly use in diagnosing NF1. We don't use genetic testing as much. So quickly through the criteria: 6 or more caffeole macules, more than 5 millimeters in their widest diameter for prepubertal children, and more than 15 millimeters in their widest diameter in postpubertal patients. Criteria 2, 2 or more neurofibromas, or one type, or 1 plexiform neurofibroma. 3, freckling in the axillary or inguinal regions. 4, optic glioma. 5, 2 or more iris hematomas or Lisch nodules. 6, a distinctive bone lesion. And the bone lesion can be sphenoid wing dysplasia, could be pseudarthrosis of the tibia, severe vertebral problems, as much as scoliosis, and also thinning of long bones. And lastly, a first-degree relative with NF1, parent, sibling, or child. So there's 7, you need 2 of the 7 to make a clinical diagnosis of NF1. But I'll tell you a little later about the problems with that type of diagnostic criteria. Okay, so now we'll switch over to neurologic findings. I was asked to talk about everything except tumors, brain tumors. So I chose to start off with what are the progressive neurologic problems and what are the static neurologic problems. The progressive ones would include CNS tumors, which Dr. Harrod will talk about, and spinal tumors. I will speak on cerebrovascular disorders or the Moyamoya Disease, the vasculopathies of NF1, and also touch on hydrocephalus, but this is not a major problem in NF1. But if there's multiple tumors, they can press onto the CSF circulation and cause hydrocephalus. And occasionally, NF1 patients have an associated aqueduct stenosis, which is part of this condition, and that can give rise to hydrocephalus. So these are progressive neurologic conditions. What about static ones? Static, some of them are actually progressive too. The main concerns in this area are learning problems, neurodevelopmental delay, motor and speech language delay, behavior disorder, and also autism spectrum disorder, which is increasingly being recognized in this condition. Seizures, headaches, and macrocephaly, big heads. And the big heads are actually due to big brains. So these are some of the static conditions that we need to address in these patients. What about mental function and unidentified bright objects? I'm just going to comment a little on this entity. Now, if you look at mental function in a group of, in a good sample of NF1 patients, you'll find that about 10% of them have mental impairment, and 40 to 50% have ADHD, and 40 to 60% have specific learning disability. And there is a high association with autism spectrum disorder. So it is a significant problem, and we have to recognize it as a significant problem of learning. So you need to have avenues of communication with the teachers and with the learners if you are going to be helping them in this area. At our clinic at Dell Children's, we have a dedicated social worker for this purpose, as well as a dedicated neuropsychometry person to help us with this significant problem. And it has caused a lot of heartache for parents and teachers. Now, no one knows what the etiology of the learning problems in NF1 is secondary to. No one knows the etiology. Some time ago, there was identification of something called UBO, unidentified bright objects. These are actually myelin vacuolization products. They are non-neoplastic and may represent, people thought, potential biomarkers for cognitive and behavioral dysfunction in NF1. However, different studies done at that time did not find this to be a true association. Why is it important? It's important because in some studies, 43 to 93% of NF1 patients show UBOs, and focal areas of high signal intensity, the so-called unidentified bright objects, on magnetic resonance imaging depicts the UBO. And in the year 2000, there was a person called Di Bella who proposed this as a new diagnostic sign for NF because it occurred in such a large number. However, that did not carry any weight. And UBOs characteristically primarily affect the basal ganglia, the thalami, the medial temporal lobes, the cerebellar hemispheres, or the brainstem. I'll show you some cartoons of this. Okay, here is a series of axial MRIs showing these high intensity lesions in the basal ganglia, here in the medial temporal lobe and hippocampus, and here in the cerebellum. These are very characteristic locales for UBOs. The characteristic thing about UBOs is that they can grow in size and they can shrink and disappear. And when they are large, they pose a differential for a tumor, like a glioma. So that's something we need to keep in mind as well. Some of them are mistaken for gliomas, only to find that with the next imaging, they have disappeared. Okay, what about neurodevelopment? So children with NF1 have mild motor developmental delay. They seem to have hypotonia, which improves with the ages and with PT and OT. They also, apart from motor developmental delay, they also have increased speech language issues, and they have velopharyngeal insufficiency, and they have articulation and disfluency problem. Their hearing, however, is usually normal. And about 50% of these patients have some type of learning disability. And the intellectual disability is actually in the minority. And if present, intellectual disability, if present, it is said that one should look for chromosomal microdeletion. There seems to be an association of intellectual disability with genetic abnormalities. What about social difficulties? It's very common. There's anxiety and problems with coping. There's unknown rate of autism. Most papers would put it around 30 to 35%, but I feel there might be more. There's suspected increased susceptibility of NF1 patients for autism. And these patients are typically evaluated and managed by therapists, psychologists, neuropsychologists, and social workers. And a lot of them do have positive outcomes. What about learning disability and other cognitive disorders? About 75% of NF1 patients will have academic deficiency in common topics like mathematics, reading. They will have motor skill impairment, as mentioned previously, ADD, ADHD in 50%, and in a smaller percent, intellectual or cognitive disability. And 504 accommodation plans and individualized education programs are frequently utilized in this group of patients with good outcomes. Okay, so let's leave the mental function, and I'm just going to talk very briefly on seizures and headaches. There's an increased susceptibility to develop seizures in patients with NF1. Not sure why this is so. It may be because of structural abnormalities or brain tumor formation or vascular abnormalities in the brain. It can occur at any age, and it is common to have focal rather than generalized seizures. And if you have focal seizures, one is concerned for focal CNS lesions. And these patients can get routine EEGs, or if they are subtle seizures, they can be admitted for long-term monitoring. And we have several of those patients in our center at the moment. What about headaches? Headaches in NF1 are mainly migraine type. For some odd reason, migraine type headaches are more common in patients with NF1. We don't usually image them because they are easily controlled with common migraine treatments, which are rescue medicines and maintenance medicines. Okay, now what are the indications for neuroimaging studies in children with NF1? If an NF1 patient has focal sensory or motor symptoms, new onset of seizures, headaches that are increasing in frequency or severity, and if there are signs of increased intracranial pressure, like alteration in level of consciousness, headaches, visual disturbance, or increased lethargy or encephalopathy, these are all indications for getting neuroimaging. As you know, we are not keen in imaging young patients, especially those under 5, with no significant reason as given in this slide. Also, if patients have stroke-like symptoms, they have decline in visual acuity or visual field, and precocious puberty or accelerated growth. Head and neck plexiform neurofibromas, which are increasing in size, or with new development of pain or new disfigurement, those patients also are due for MRI. They have the indications for MRI. Okay, what about vascular complications? That is blood vessels and the heart. Today we'll just talk about the blood vessels. There is a significant but under-recognized complication of NF1, and in several studies, up to 20% of NF1 patients may develop hypertension, and this may be secondary to a vasculopathy involving the renal arteries. Remember, both arterial and venous blood vessels of all sizes are affected in NF1 vasculopathy. Now, neurofibromatosis, which is the tumor suppressor gene, is expressed also in endothelial and smooth muscle cells of blood vessels. And it is thought that this is likely to be involved in the pathogenesis of NF1 vasculopathy. NF1 vasculopathy basically involves stenosis or occlusion of the blood vessels. And the blood vessels that are involved are mainly cerebral or visceral vessels causing infarcts. You can also get aneurysms, and these can bleed, or you can get AV fistulas. The funny thing is that most NF1 patients who have vasculopathy are asymptomatic, and the increased mortality has been reported in patients with NF1 and vasculopathy when compared to other aspects of NF1. And the characteristic NF1 vascular lesions you would see would involve the entire arterial tree, but involvement of the renal arteries with consequent hypertension is most common. Cerebral vascular lesions can be patchy, and the typical one is the Moyamoya type vasculopathy. Now, this slide is busy, but it depicts the clinical characteristics of children with neurofibromatosis type 1 associated cerebral vasculopathy. This was a study that we did at the Cleveland Clinic and published in the Journal of Child Neurology several years ago. We had 15 patients from a total of 312 who underwent brain MRI and had cerebral vasculopathy. That means 4.8% of this 312 patients. And the mean age of these patients was 4.3 plus or minus 3.5. So around 1 to 12 years, so wide range of ages. 53% were boys, and the mean age at the time of diagnosis of their vasculopathy was about 11.7 plus or minus 7.3 years, 2 to 18 years. The indications for neuroimaging were headaches in 5, seizures in 2, brain tumor in 1, and screening for intracranial complications in 7 of the total 15 patients. None of the patients had focal neurologic deficits or complications attributable to their vasculopathy at presentation or at the time of the radiology follow-up. So if you look at the modalities of evaluation as expounded by the American Heart Association in 2008, they recommended routine vascular screening with MRA in children with high risk and relatively common disorders on the management of stroke, known to cause Moyamoya syndrome. So conventional angiography is really the gold standard for evaluating blood vessels or evaluating vasculopathy in NF1. However, there is a small risk of stroke of 0.7%. Magnetic resonance imaging is important because there's no ionizing radiation and it is non-invasive. Computer tomographic angiography, CTA, is also important, but remember it has ionizing radiation. Okay, let's talk about Moyamoya disease very briefly. Now, chronic progressive stenosis or occlusion arthropathy of the distal internal carotid artery, and less often stenosis of the proximal anterior cerebral arteries and middle cerebral artery, basilar artery, and the posterior cerebral arteries. So around the circle of Willis, nearly all the vessels that congregate there can be involved, but the internal carotid artery is the commonest, and then the anterior cerebral, posterior cerebral, the basilar artery are other arteries that can be involved in this Moyamoya process. Also, Moyamoya may involve extracranial carotid and vertebral arteries as well. And what's the clinical presentation? They present as transient ischemic attacks, strokes, headaches, or cognitive decline. Some of them are asymptomatic. And the clinical radiologic dissociation is where the radiologic progression is seen without development of any clinical symptoms. So that's another feature that you need to keep in mind when you are following these patients, that they may have no clinical progression, but MRA or MRI may show that. Here's images on the right, an axial image. I'm not sure whether you can see this arrow showing a mesh of blood vessels in the right, where the right middle cerebral artery takes off, but better seen here. Here's the internal carotid artery I was talking about on both sides. Here's the basilar artery, and here are the posterior cerebral, and here the anterior cerebral. These are the areas that are typically affected by Moyamoya, in particular, the end of the internal carotid and the beginning of the right middle cerebral artery in this patient. You could see a clear middle cerebral artery on the left, but you don't see it on the right. Instead, you see a mesh of vessels here. And this is called the Moyamoya group of vessels, and Moyamoya means a puff of smoke. Okay. Let's talk about MRI and MRA. Disadvantages would be timing, the sedation, the anesthesia, and resources in different hospitals and logistics. Those would be disadvantages. But if those are not a problem, then using MRI and MRA would be valuable. So imaging findings, they might be subtle and maybe overlooked. So you need to have an awareness of the problems that you see on imaging. Early detection is important because of timely intervention. MRI and MRA is said to be better to delineate the intracranial vasculopathy than if you do just MRI. So consider adding MRA to MRI brain for any indication in children for early detection of cerebral vasculopathy. Treatment of Moyamoya disease or cerebral vasculopathy. You have a couple guidelines, and I'll just go through it quickly. The surgical and medical guidelines. This is a revascularization surgery. Surgery is associated to several complications, mainly in the pediatric population. And the surgical treatment is usually done by plastic surgeons and neurosurgeons, and it has to be considered very carefully. And what they do is you have a direct revascularization from the brain and the dura and the arterial system outside. So it's a synangiosis between inside and outside, and you bypass the stenotic or occluded area. And in the post-surgical period, these patients are put on antiplatelet drugs to prevent clotting. Okay, so let's talk a little about what's new in NF1. I'm going to go rather quickly through this. New clinical syndromes. There are new clinical criteria, which I'm not going to go into detail, and new clinical trials and novel drugs. That was already discussed this morning. I'm just going to touch on it. Okay, so the new clinical syndrome. Don't forget Legious Syndrome. Legious Syndrome, the clinical criteria is multiple caffeole spots and skin fold freckling, plus or minus macrocephaly. So if you look at it, it has two of the criteria for NF1, two of the 1987 diagnostic criteria. So if you see these patients, the diagnosis could be NF1. But these patients do not, when followed up, form optic gliomas, neurofibromas, or Lisch nodules. They don't form tumors. So that's the difference between Legious syndrome and NF1. And because of this difference, researchers have looked at their genetic makeup and found that the NF1 gene was intact in these patients, but there were mutations of the spread1 gene on the long arm of chromosome 15, making it a separate genetic entity from NF1. And this has a fairly better prognosis than NF1. So it's important to always look for Legious syndrome in your patients who do not have spurious clinical features of NF1. So it's also said one should consider routine NF1 gene testing, especially for sporadic cases, namely patients with no family history of NF1. The new clinical criteria is similar to the old one, but there are some recommended changes in red. For example, cafe au lait spots. In the new one, they must be bilaterally localized. Unlike the old one, it could be just unilateral. Axillary and inguinal freckling, again, must be bilaterally localized. Lisch nodules is not only accepted. If you have 2 or more choroidal abnormalities, they can replace this. So already you have a couple changes. Optic glioma is the same, and distinctive osseous lesion apparent with NF1 by the above criteria, and 8, a pathogenic NF1 variant in addition to the existing clinical criteria. And then unilateral freckling and cafe au lait spots raises concern for mosaic NF1 and not NF1. That's why they want it to be present bilaterally. Here are the choroidal tubercles that I was talking to you about. Here's the arrow, white arrow, showing you these tubercles. And they can be small to large, and they are found in a large percentage of patients with NF1. And that is why at one stage people wanted to use this as a diagnostic criteria for NF1. Lastly, clinical trials and novel drugs. I'm not going to concentrate, I'm just going to mention it. The NF1 gene encodes a protein neurofibromin, which regulates the RAS signaling pathway that controls cell proliferation and acting as a tumor suppressor gene. Over the last 15 years, there has been tremendous progress towards identifying effective drug therapies for the neurofibromatosis via the clinical trials, which is supported by the NIH and CTF. So we started early on with thalidomide, interferon, pirfenidone, and then moved on to rapamycin, everolimus, selumetinib, and now other drugs, including everolimus, vincristine, carboplatin, etc. Okay, we are now concluding. Diagnosis of NF1 is mainly clinical still, using the NIH diagnostic criteria. There's an important role for pediatricians in improving outcomes by identifying signs leading to a diagnosis and appropriate tumor surveillance and treatment. So big role for pediatricians and primary care doctors. Imaging indicated when there are symptoms and or abnormalities during neurologic, ophthalmologic, endocrinologic, orthopedic examinations. More data is needed to determine when to perform surveillance and get surveillance for imaging by whole body or regional MRI. We don't really have solid guidance for this. And I think this is going to be helpful in the further management of our patients with NF. Vascular problems in NF were thought to be minimal, but now it is known that patients with NF1 have an increased risk of developing vascular complications in both blood vessels, arterial and vascular, and even in the heart. NF1 is a lifelong condition, and some of the complications are more likely to occur among adults, so developing an adult transition program is of utmost importance in the appropriate care of patients with NF1 across the timeline. And we are at the Dell Children's trying to develop an adult transition program for this purpose. Okay, thank you very much. And if there are questions, I can take questions with Dr. Harrod when she's over.
Thank you, Dr. Moodley. That was excellent. That's a lot of, all these kind of non-tumor issues are just of great concern. We did get a couple questions that came in that I think Dr. Harrod, I think it'd be relevant to have Dr. Moodley answer now before you get started. Would you, related to Moyamoya, would high blood pressure be related to Moyamoya or other? We know that that's a symptom more of renal vasculopathy. Is that also with Moyamoya?
Yeah, it is not part of Moyamoya. The hypertension in NF1 patients are due to several causes. The most important is renal artery stenosis. Secondly, you should look for an association with pheochromocytoma. Thirdly, there might be a neurofibroma that's in the kidney pressing on the renal artery. Not renal artery stenosis from NF, but from a tumor. And lastly, it could be idiopathic hypertension. So those are the four causes of hypertension in NF1, and Moyamoya is not really one of them.
And is that pheochromocytoma, is that the adrenal gland tumor?
That's it.
Okay.
Yeah.
Okay.
And you can look for it. We normally would send such patients that we suspect has pheochromocytoma to the endocrinologist.
Okay.
And renal specialists.
Okay, what is the typical size of a UBO?
Typical size.
I don't know that there is one.
Is there one?
Yeah. You know, they vary in size from very small to large as a glioma, maybe 3 to 4 centimeters. Dr. Harrod sees gliomas. What's the biggest glioma you've seen?
Oh,
5?
you don't want to know. Yeah, they can.
Yeah, they
all-consuming.
vary from a few millimeters to maybe 5 to 10 millimeters.
Yeah, and I think one of the things that to keep in mind with UBOs is they can also increase over time, and then they can decrease in size. So there's not really an average size, but there is a pattern of change similar to cafe au lait spots, how they can get larger over time. But then there's a time point you expect them to not be getting larger. And that would be more concerning if you continued to see it get larger in the adolescent teenage population.
Yeah, they do, disappear with time. They get bigger. And that's when there's always this question of, is it a glioma? Mm-hmm. So they can increase in size to centimeters.
Okay, and I think one more question before we move on to Dr. Harrod. In terms of focal seizures, do seizures in people with NF manifest themselves the same way as if in epileptic seizures or different types. I guess just having a better understanding of focal seizures.
Yeah, they manifest seizure semiology in a similar way as seizures in other patients. But if they have localized lesions, like a tumor or a structural problem or a vascular problem, then they present with focal seizures. And focal seizures means one side of the body is affected, while generalized both sides. And focal seizures are common in NF1 patients, although generalized seizures can happen as well. But it is an indication to image the patient, do neuroimaging, because you may find a tumor or you might find a vascular malformation.
Okay. Very good. Thank you again, Dr. Moodley. We appreciate
Thank you very
here.
much.
It's great information. And if we didn't get to all the questions, we will try to get them answered. But we